Just going to do a few introductions before we get started. So my name is Rebecca Simmons, and I am an assistant professor in the Division of Family Planning at the University of Utah. And I am joined here today by some of my colleagues. So we have Misha Pangasa, who is our Senior Family Planning Fellow, and Misha is going to be monitoring the chat throughout our presentation for any questions that you might have around the different aspects that we're going to talk about today. And she'll also guide our Q&A at the end of this session. I'm also joined by Caitlin Quaid, who's the Director of Family Planning Elevated, which is the project that these trainings are under, and Sarah Elliott, who is our Assistant Director of our Family Planning group. So thank you everybody for joining us, and we are just going to move right in. So next slide, Sarah, and we'll do the slide after that as well. So I want to just give you a quick sense of who we are in terms of a team. So Family Planning Elevated has a very colorful but pretty simple mission. We believe that all people deserve equitable access to all contraceptive methods at all times and in all communities. And our team does that through training, technical assistance, and support to clinics, pharmacies, and community organizations throughout Utah. So a few quick housekeeping notes. Everybody should be muted, but we do encourage your participation. Please feel free to ask questions in the chat or to raise your hand using your reactions button, or even use annotations if you know how to do those. We will be checking the chat throughout the session and looking for your interactions so that we can get to everything that people would like to know. At the end of today's session, I will talk through the instructions for claiming CME credit. There is one CE offered here for this webinar today. And then we'll also set aside a few minutes at the end for you to complete your post-webinar survey and talk through any questions you may have. We really do appreciate your feedback and giving us that survey information. It's only about 4 questions, but the responses really do help us improve this training so that it's more relevant to what pharmacists want to know. So here's our CME disclosures from our office. And then moving forward, so why pharmacists? So this is probably a question you already have your own answers to, but as we get started, we thought it might be good to share a little bit of the research that we have on the role of pharmacists and pharmacy dispensing in improving access to contraception. So because we're researchers, we couldn't resist sharing some of this excellent research around pharmacy dispensing of contraceptives. So this first study highlights who might be wanting access to contraception in pharmacies. And unsurprisingly, these are folks whose needs are not being met by the more traditional routes of contraception. So multiple studies have found that pharmacy clients are typically younger, they're less educated, and they're more likely to be uninsured and report having a primary care provider than people seeking traditional healthcare facilities. The second study showed that a significant majority, 79% of people who were using pharmacy dispensing felt that it improved their ability to access contraception. And then the findings from the third study are really interesting because this study compared experiences of people who obtained care through pharmacies with those who obtained care through healthcare facilities. And the study found that patients who saw pharmacists were more likely to say that they would repeat services with that same pharmacist compared to people receiving services through a healthcare provider. So pharmacists are really playing a unique and important role in improving contraceptive care and access through pharmacy dispensing. And then this next slide gives a little bit of our own research that we've been doing on patient perspectives of pharmacists in providing contraceptive care, and just a couple of quotes from one of the focus groups that we conducted. So somebody said, "I think I'd also be more comfortable talking to a pharmacist because it's their job to administer different kinds of medication. And I feel like if they see so many different things, they would probably not be very judgmental." And another person said, "I'd be comfortable just because of that aspect of them being able to give you a little bit more insight into your personal drug use." So now that we've had a very quick glimpse into the why, let's get into the nitty-gritty of how. We are going to cover 5 different hormonal contraceptive methods today: progestin-only pills, combined estrogen-progestin pills, contraceptive patches, vaginal rings, and emergency contraception. So right now, emergency contraception isn't currently covered under pharmacy dispensing, but the Board of Pharmacy has said that this is something that they are interested in moving forward with to make this available through the dispensing. So it's not available right now, but do stay tuned on that for more information. We're going to start with progestin-only pills because these are traditionally the most straightforward method of the pharmacy available methods. Since they don't have ethinyl estradiol, there are fewer contraindications to their use than combined methods. So some people choose POPs because they provide a very rapid return to fertility. They can be used immediately postpartum, post-miscarriage, or post-abortion, and they are an easy option for people who have contraindications to combined hormonal methods. So there are 4 different types of progestins that are used in POPs, but the more commonly used progestin is called norethindrone, and it's to a lesser extent drospirenone. So for norethindrone progestin pills, there's a lesser amount of the progestin in the POP compared to norethindrone combined pills. This isn't the case for drospirenone, but again, since norethindrone pills are more used, this helps to explain why there's such a rapid return to fertility for these methods. So these methods typically work through a variety of mechanisms, including thickening the cervical mucus, thinning the endometrial lining, and sometimes through suppressing ovulation. However, due to the lower levels of the progestin, return to fertility is very fast. And in order to take these pills correctly, the person must take them continuously and at the same time every day. So if somebody takes the pill more than 3 hours later than their usual time, they need to use a backup method of contraception like a condom for 2 days. Unlike combined pills, these pills do not have a placebo week or a placebo time. Clients need to take them continuously without stopping. So the requirement to take these pills at the same time every day without breaks is why we see such a big difference between effectiveness for typical use and perfect use. When discussing these methods with clients, sometimes showing them those differences in efficacy can be a good starting point to help them strategize how they want to maintain consistency, if that's what they're after. So this next slide is around contraindications. And as you can see here, there are very few contraindications for progestin-only methods compared to combined methods. So the 2 areas that we see of overlap include having a diagnosis or history of breast cancer and the use of some medications that impact effectiveness. So we'll come back to this slide again, but the take home here is that most people are eligible for POPs. On the topic of contraindications, I do just want to take a minute to acknowledge that while there are some contraindications to contraception, overall, these methods are uniformly safe and effective for most people. So even people for whom a contraceptive method is contraindicated, for example, somebody who smokes and is over age 35, these folks still have a very low risk of an adverse event. And importantly, the risks of that adverse event from taking contraception are much lower than the risks that someone would face while if they were to become pregnant. So that same 36-year-old smoker is much more likely to have a thromboembolic event if she were to become pregnant than she would be from taking contraception. So while we want to make sure that we're keeping clients safe, it is just important to note that contraception is safe for almost everybody. So getting back to these POP side effects that we typically see, the main side effect that clients report typically is a change in bleeding. And this is actually the main reason that many people discontinue these methods. So people using norethindrone POPs tend to have longer menstrual bleeding at shorter intervals and a higher likelihood of spotting in between menstruation. About 50% of people report having these bleeding changes, so it's quite common. You can let a client know that if they happen to fall in that 50% and it becomes a problem that they don't want to deal with, other progestin-only methods like the levonorgestrel IUD often result in very, very light periods or amenorrhea. So they do have other options if that bleeding is something that's really an issue for them. For some people, progestin-only methods can also cause acne flare-ups, breast tenderness, decreased libido, mood changes, nausea, and an increased likelihood of developing ovarian cysts. So if patients are experiencing these side effects, they do not have to stay on POPs. There are other progestin-only options that they can try. So, when specifically discussing POPs with a client, the main point of conversation is to help them strategize how to maintain that consistency with their pill taking. So, talking with them about those ideas about how they're going to remember to take the pills every day. For example, many people find it beneficial to set a pill alarm in their phone that just goes off at the same time every day. And then just reminding clients that if they miss taking a pill for more than 3 hours after their normal time, they take that pill as soon as they remember it. They don't need to take more than one. And then they need to use condoms for the next 2 days. So people who are just getting started on POPs might want to purchase a pack of condoms to have as they get in the habit of taking those pills consistently. And then you can remind clients that unlike other types of birth control pills where there might be placebo pills, progestin-only pill packs don't have those placebos. And then finally, this is a really good place to offer EC as a backup in case they need it. We're going to talk about EC a little bit more in a minute, but many people who are on POPs could benefit from having that advanced provision of emergency contraception. Both types of the oral EC work well with progestin-only pills, although if somebody uses ulipristal acetate, there's a need to also use condoms for some time after taking it, which we'll talk about later. So moving on to combined methods, we're going to talk about these as kind of a group at first and then talk about them separately moving forward. So we have combined pills, contraceptive patches, and vaginal rings. All of these methods contain an estrogen, typically ethinyl estradiol, and some form of progestin. So combined hormonal methods inhibit gonadotropin releasing hormone, luteinizing hormone, and follicle stimulating hormone, all of which contribute to suppression of ovulation. But that FSH suppression, which is preventing follicle development, is likely the main way that these medications work. The progestins in combined methods also support reducing fertility by thickening that cervical mucus and reducing the endometrial lining. It's important to know that things that where a person is in their cycle and whether they've had a recent wellness check don't factor into somebody's ability to safely start combined methods. So to reasonably rule out a pregnancy, it's sufficient to simply ask the person whether or not there's a possibility that they could become pregnant. If somebody happens to be pregnant and they don't know that they're pregnant and they start taking these methods, they're not going to harm an existent pregnancy. They just won't work. So once started, these methods can be used until the client no longer wants to take them. And they don't require a follow-up, though if somebody wants a follow-up, that's fine. It's just not necessary. So coming back to this list of contraindications, but this time focusing on combined methods, most of you are familiar with the US Medical Eligibility Criteria app and how to use it to determine contraindications for various types of hormonal contraception. And this is going to be the main and best approach to assessing suitability for use of combined methods. For combined methods, the main contraindications are either things that reduce the efficacy of the medication or things that increase the likelihood of a thromboembolic or cardiovascular event. So for example, concurrent medications like some anti-seizure medications, a few types of antibiotics, antifungals, and antiretrovirals may reduce the efficacy of these methods, as does the supplement St. John's wort. Those medications also affect progestin-only pills. So if somebody is taking them, a method like a copper IUD might be a better form for those people. Many types of medications that affect efficacy are quite specific. So it's not worth turning somebody away just because they're on an anti-seizure medication. It's worth using the US Medical Eligibility Criteria app to just make sure, because it's just really only one or two of these medications that have this effect on efficacy. So the other risk area that I like to mention is this thromboembolic or cardiovascular event. Smoking, people with uncomplicated or complicated diabetes, people with uncontrolled hypertension, people with migraines that have aura, and those in the immediate postpartum period are at higher risk generally of having a thromboembolic or cardiovascular event. And that increases when they're using a combined hormonal method. So for people with these conditions, progestin-only methods or non-hormonal methods are recommended. So for each of the combined methods, there are some method-specific side effects, but the more common side effects are the ones that are seen across the category. So when discussing possible side effects with a client, one of the most important things to let them know is that some people don't experience any side effects, and some people experience all the side effects. And there really isn't a way to know how somebody is going to do on a particular method. So when counseling, you can assure clients that if something isn't working for them, it's perfectly fine to come back and try something different. Side effects like breast tenderness, nausea, and bloating may happen when somebody is starting a combined method. If they are going to resolve, they usually do so in the first month. Things like breakthrough bleeding or irregular menstrual cycles may also happen, but again, these tend to resolve in the first 3 months of use if they're going to. And then other longer term side effects like mood changes or changes in sexual function are just something to look out for. And you can let clients know that if they do experience these, they're not alone, that these are something that happens, and they have other options. So with all combined methods, a new user needs to use a backup method for a week after initiation to give those hormones time to work. With all methods of contraception, it's good practice to ask a client if they have a different method they want to try, if this particular method doesn't work out. And there is some evidence that when people have a backup plan, it's easier for them to ultimately switch methods and to be happier with their experience. Again, this is a good place to ask them if they'd like some emergency contraception with their regular prescription. You can let clients know that if they have an accident or if they're inconsistent with their method, they can take that oral levonorgestrel EC at any point in the cycle. And they can also take ulipristal acetate, but if they do, they need to use condoms for the next 2 weeks. We're going to talk specifically about combined hormonal pills. So these methods are some of the most popular methods in the US, and many people like them because they can improve menstrual and pelvic disorders, temporarily suppress acne, and they can reduce the incidence of ovarian cysts. So there are more than a dozen different types of progestins that are commonly used in COCs, but the type of progestin isn't typically a factor that we take into consideration when choosing a particular COC for a client, because the evidence has shown that there are relatively minimal risks across the board for the different progestins. So some people do report fewer side effects on third generation progestins compared to earlier generations, but we also see a slightly higher incidence of thromboembolism in this generation. So again, there are kind of these trade-offs across the board. So the main decision point between COCs tends to be the level of estrogen. The current recommendation is to prescribe a pill with between 20 to 35 micrograms of ethinyl estradiol versus higher or lower doses. And usually with new users of COCs, we like to start with those 20 micrograms of ethinyl estradiol and only increase estrogen amounts if they're experiencing breakthrough bleeding. I will say, though, that many patients don't know that there are different doses and different progestins. So if somebody wants to stay on a COC, but they're experiencing side effects with the one they're currently using, you can let them know that there are other types that they could try, and they may have a different experience. So COCs can be multiphasic or monophasic, but the general recommendation is to prescribe monophasic pills because they're easier for the client to use and they're likely more effective when they're being used for continuous cycling. COCs are also packaged as either 21/7 or 24/4 active or inert pills, but the preference is currently to prescribe for 24 and 4 if possible, because this tends to suppress ovulation more fully and results in less withdrawal bleeding typically. So if a patient is using a monophasic COC, they can take active pills without needing that withdrawal bleed or without needing to use those placebo pills. A Cochrane review comparing continuous cycling to traditional cycling found that there were few overall differences between the two groups, but those continuous cyclers tended to report better bleeding patterns and had fewer side effects compared to the other group. So this decision is really based on client preference on bleeding. So some places have different rules and recommendations around this, but if talking about combined pills broadly, you can just let patients know that continuous cycling is a safe and reasonable option for this method. So there are a few things that are typically covered when discussing COCs. You can let the client know that typically 7 in 100 people will become pregnant within the first year of using this method with typical use. And usually people who become pregnant while using COCs do so due to errors in their pill management where they forget to take them. But you can also let people know that they may want to pay attention if they start a new medication, as we talked about, because some of those medications do reduce COC efficacy. So if a person misses one pill, let them know that they just take the pill as soon as possible, as soon as they remember that next day. If they miss 2 or more pills, tell them to take their next scheduled pill when they remember it, and then use condoms or another method backup for a week. And they may also want to use emergency contraception, which we're going to cover. So as mentioned, you can also discuss their personal preferences for a withdrawal bleed or continuous cycling. And you can also ask if they have a particular COC they want to use. So some people do have preferences around a brand that they want to try or something that they've been using successfully in the past. If a client wants to use a brand name COC, what we typically do is look up both the cost of the brand name and the cheapest generic counterpart and offer them either one. So now we're going to move on to the transdermal contraceptive patch. These patches are highly effective estrogen progestin contraceptive methods, and there are currently 2 types of patches, both of which are applied as a new patch once per week by the user. So the first is the ethinyl estradiol norelgestromin, which commercial names are Xulane and Zafemy. This method contains 3 layers, including an outer water-resistant protection layer, followed by that medication and adhesive layer, and finally the liner that's removed before the patch application. The middle medicated layer contains 35 micrograms of ethinyl estradiol and 150 micrograms of norelgestromin. However, it's important to note that the ethinyl estradiol exposure to the user is approximately 60% higher when compared to those oral contraceptive pills of a similar dose. And that's just because of that transdermal method of delivery compared to the oral delivery. So the second type of patch is the ethinyl estradiol levonorgestrel patch, which is commercially named Torla. And that was recently approved in 2020 by the FDA. This patch releases 30 micrograms of ethinyl estradiol and 120 micrograms of levonorgestrel. And it has a similar exposure to the oral contraceptive pills of the same dose. It is a slightly larger patch than the other version, and it consists of 5 layers, with those 2 innermost layers being the medication layers. So unlike pills and vaginal rings, the evidence does not support continuous cycling with the patch because of that increased exposure to the ethinyl estradiol and then the increased risk of thromboembolic events. If somebody happens to use them continuously and that's what they want to do, it's not going to be the end of the world. But we do recommend counseling patients to give themselves that placebo week with this method. So patches are contraindicated for anybody with a BMI over 30. This is due to both the increased risk of thromboembolism and the lower efficacy within this population. So another important consideration is if the person is being treated for Hep C, and then sometimes if they have a previous history of skin hypersensitivity. Usually this is something that people who are patch users just identify after they've been using it, but if somebody's coming with skin hypersensitivity, this is something to know. Efficacy for the patch is quite high. Studies of the estrogen norelgestromin patch have shown that perfect and typical use efficacy are almost the same, which indicates that this method is relatively easy for people to use. Studies of the ethanol levonorgestrel patch have found lower rates of typical use efficacy, which is that 6 pregnancies per 100 women in the first year. This isn't indicative of differences between the two patches, but probably just some differences in the studies done on them. We'll get more information as more of the levonorgestrel patch information starts to come out. This is a really good method for people who have trouble remembering pills. And there are several places a person can apply the patch. So the outer bicep, the abdomen, the upper torso, such as the shoulder, or the buttocks. Due to the high levels of estrogen in the patch, it's not recommended that people place the patch near or on their breast tissue, as this tends to result in increased breast tenderness. So when a client is switching their patch each week, they should do it on the same day and should be counseled to put the patch in a different location than they had put their previous patch. So for example, if they had it on their left shoulder, they can put it on their right shoulder or somewhere else. The patch has been tested in many environments and it is pretty hard to detach, but if it does become partially or completely detached and it's been less than 24 hours, you can let somebody know that it can be reapplied at the same location, or they can just use a new patch if reapplication is not possible. If it's been detached for more than 24 hours, a new patch should be reapplied, and then the weekly cycle would start on that day going forward. If somebody forgets to apply a new patch for more than 24 hours, they need to apply it as soon as they remember, and they should use that backup contraception for a week. So when discussing the patch with a client, the levonorgestrel patch is usually a good patch to start with because it typically has a slightly lower side effect profile. Again, the patch is a really good potential fix for people who have trouble remembering to take medications daily, but this is one of the less private methods and might not be appealing to everybody. It's also very expensive for people who don't have insurance, and so cost might be a factor here as well. So like COCs and the transdermal patch, the vaginal ring is a combined hormonal contraceptive, but has a longer duration of contraception and may be appealing to people who want the benefits of combined COCs, but don't want to be tied to that daily or even weekly compliance. So there are 2 available options for vaginal rings: the etonogestrel ethinyl estradiol ring, which is inserted and used for 21 days, and then discarded for a week to allow for that withdrawal bleed. A new ring is then inserted at the end of the ring-free week. After insertion, there's an immediate release of that serum hormonal concentration, and then a slow decrease over the next 2 weeks. Peak etonogestrel occurs about 7 days after insertion. So the ring has a longer concentration of ethinyl estradiol than other combined hormonal methods, and this particular ring must be refrigerated when it's not in use. The other ring is the progesterone ethinyl estradiol ring, which is called Anovera. It can also be inserted for 21 days and removed for a week, but unlike the etonogestrel ring, the progesterone ring is cleaned and stored during the ring-free week and then reinserted after 7 days for another 21 days. This option can be used for 13 consecutive cycles, so it can be a longer-term option for people who want it. The device releases approximately 150 micrograms of progesterone and 13 micrograms of ethinyl estradiol over the 21-day period. And then unlike the monthly option, this particular method doesn't require refrigeration. So vaginal rings also have the additional contraindication that they are not good for anyone who has undiagnosed or abnormal uterine bleeding. So just being aware of that. There are a few things that are typically covered when discussing vaginal rings. You can let the client know that typically 9 in 100 people become pregnant within the first year of using that etonogestrel ethinyl estradiol ring, while 3 in 100 people become pregnant using the progesterone ring. Again, like the other with the patch, the difference in efficacy is possibly due to the fact that there are a differential amount of studies on each of these methods, but we won't know until we have more data on the Anovera ring. So to insert the ring, a person squeezes it between their fingers and inserts it into the vaginal canal. Placement of the ring doesn't really impact the efficacy of it, but the higher it's placed, the more comfortable it's going to be, and the less likelihood it has of falling out. So higher toward the cervix is typically better. So a person needs to keep the ring inserted at all times, including during sex. People who choose this option should know that they need to use water-based lube if they're using lube, not silicone, because the silicone will degrade the vaginal ring. If the ring falls out, it should be cleaned and reinserted as soon as possible. If it is out for more than 2 to 3 hours, a person needs to use backup contraception for a week as well. So cleaning the progesterone ring, people need to use like a mild soap, such as a dish soap or water, not any harsher products, as again, that will result in the degradation of the ring. So we've now covered pills, patches, and rings. As promised, the other type of contraception we want to discuss is emergency contraception. Many people think of emergency contraception as something that is just that, something that's only accessed in emergencies, but multiple studies have found that having emergency contraception on hand as a preparedness step is really an important way to reduce unintended pregnancy. So we like to have the discussion around emergency contraception incorporated into discussions around any method. So clients who know the options and have a plan in case there's a problem are going to be better able to execute that plan in the event that they end up needing emergency contraception. So methods of EC available in the US include oral pills and intrauterine devices. So IUDs are the most effective form of EC available. So even though a client can't access an IUD in a pharmacy setting, I just want to note that both the copper and the levonorgestrel IUD are an option for clients. It's important to know that no matter what method of EC a client chooses, it's only effective if initiated within a specific time after unprotected sex. So the timing is really the big issue here. So the two types of oral pills are the levonorgestrel oral EC and the ulipristal acetate. And their mechanisms of action are really well documented and widely understood. Both of them work by delaying ovulation. Importantly, neither of these methods impact implantation or an existing pregnancy, and neither of them are going to cause an abortion. Levonorgestrel is most effective when taken within 72 hours after unprotected intercourse, and ulipristal acetate is effective if taken up to 5 days or 120 hours after unprotected sex. So right now, levonorgestrel is available over the counter, while ulipristal acetate is only available through prescription. Again, pharmacy dispensing may change this and make ulipristal acetate more available to people, but it's not currently. So just, again, keep it in the back of your mind. Any person who desires EC is a candidate for EC, and all forms of EC are safe for people at any age group, including adolescents. So when it comes to discussions of efficacy, we have found that it's not as helpful to think of emergency contraception by efficacy rates like we do with traditional contraceptives, but more on a continuum. So levonorgestrel EC is the most available method of EC, but it's also the least effective. That doesn't mean it isn't effective, but it is just important for people to know that it has its limitations. And one of the biggest limitations to the levonorgestrel EC is body weight. It is less effective for people with increasing body weight starting at about 155 pounds and higher. And I just want to point out that that is not very heavy. I also want to say that that doesn't mean that it won't work for people with higher body weight. It does provide some protection, but it is a factor for people to consider. So a recent study found that people with higher BMIs didn't benefit from taking more than one dose of the levonorgestrel. So we don't recommend this as a strategy for folks in this category either. Ulipristal acetate is more effective for people at higher body weights, and both the copper and LNG IUDs don't have any changes in effectiveness due to body weight. So all methods of EC need to be initiated within 5 days after unprotected sex in order to be most effective. Since sperm can live in the vaginal tract for many days after unprotected sex, the goal of getting in that 5-day window is to delay ovulation and give the person time for that sperm to die out. So when we're thinking about how to talk to people about emergency contraception, there are a few things that patients are typically thinking about. This is one where the efficacy of the method may be very, very important to somebody, but also how much it costs, whether they can get it as soon as possible, and whether they want something that's a one-time event or may work for longer. So each patient is going to be different in their preferences, but just letting them know that they have these different options can help them think about how they'd want to approach a situation where they found themselves needing EC. A couple of additional pieces of information, both the levonorgestrel and ulipristal acetate methods can be used among breastfeeding populations. Actually, all of these can be used among breastfeeding populations, but the CDC does recommend tossing any breast milk that's pumped within 24 hours after taking ulipristal acetate. You can let a client know that taking levonorgestrel or ulipristal acetate will also likely impact their menstrual cycle if they're cycling. Depending on where they were in their cycle when they took the EC, the cycle may be longer or shorter, and menstruation may also be longer or shorter than usual. Some people also experience other side effects with EC, like headaches or nausea. If somebody throws up their EC pills, they need to take another one as soon as possible or seek out a different method of EC. If somebody is currently using hormonal contraceptives and they take ulipristal acetate, they should continue using their existing contraceptive method as normal, but they also need to use a condom for 2 weeks afterward because ulipristal acetate can interfere with the effectiveness of other hormonal methods. If a person isn't using hormonal methods when they take ulipristal acetate, they should wait 5 days before starting a hormonal method to give that ulipristal acetate time to clear their system. Levonorgestrel EC can be used at any time, but if somebody is taking EC and they're using a hormonal method, this is probably because they've missed some days, and as such, they should still be using those condoms for the week afterward. So we know patients want to be able to access contraception through pharmacists, and pharmacists are comfortable with the drug formularies and contraindications, but there is still that moment when a client actually shows up wanting birth control. And we've heard from some pharmacists that because they only see a handful of contraceptive clients, they can feel like a deer in the headlights when somebody arrives to actually talk about contraception. And while our team is not equipped to help you figure out the intricacies of counseling in your pharmacy workflow, which is your area of expertise, we are experts in how to provide person-centered contraceptive care. So we are going to share the foundations of person-centered contraceptive care today, and hopefully these can provide you some support as you're thinking about how to do this in your unique settings. So unlike areas of medicine where there is a clear right answer to what somebody should do, contraceptive counseling is more about helping select among a range of equally good options. So I love this quote because it really explains the complexity of contraceptive decision making. The quality of contraceptive programs should be based not on how many LARC methods they distribute or how many adolescent pregnancies they prevent or how much money the taxpayers save, but by how many people feel truly respected and cared for when it comes to childbearing and family formation. So we believe that a successful visit is defined by the process and not the outcome. Specifically, a successful process is one that is centered on a person's individual needs and preferences. And it is a process that is person-centered. And it's not just us that thinks this. There are different areas of places where people have also studied this and have found that this is the case. So we're going to start out with a shared definition of person-centered counseling. So the definition of person-centered counseling is care that is respectful of and responsive to the individual client preferences, needs, and values. And this means that the client's values guide the clinical decisions. And this may sound pretty obvious because, of course, we want to respect client needs, but I do want to note that it is a relatively radical departure from the traditional mode of care of provider knows best. So, this
At least
way
it
of
was
thinking,
nicely located as far as conservation.
Claire, thank you. So in this way of thinking, The conversation is with two experts, the pharmacist who has the medical expertise and the client who is the expert in their own life. So what does it look like to include people in person-centered care in contraceptive counseling? The good news is, once again, we do have some research to guide us. So you've heard of the medical eligibility criteria, but have you the MEC, but have you heard of the QFP? These are some recommendations developed by the CDC and the Office of Population Affairs. They conducted rigorous literature reviews and got input from experts in the field to provide some evidence-based recommendations about contraceptive care. So the QFP frames family planning as one of a core set of services, not just contraception, but also pregnancy testing, counseling, basic infertility services, preconception health services, STI services, etc. It's a really big, long PDF, but also is available as an app in your phone if you want that QFP app. So we're going to go through each of the QFP concepts and discuss what it might look like to incorporate these concepts in your counseling session. There is kind of an inherent oxymoron here doing this, detailing these prescriptive ideas in something that is inherently going to be a process that's individualized. And I just want to acknowledge that while these are some suggestions and inputs, they won't necessarily flow like this. And that's just to be expected. These are more of guidelines for you to use to facilitate a conversation. So step one is establishing and maintaining the rapport with the client. And this is really about the manner in which a provider interacts with a client. Obviously, good rapport is important across all health topics, but it may be a particularly important place for a client coming in for contraception because, unlike other types of medications, the client may have been having these vulnerable conversations about method selection and stopping and switching in their sex lives and their partners again and again and again over 30 plus years of their reproductive lives. So contraceptive clients report that they want an intimate and friend-like relationship with their provider when they're talking about methods. So when figuring out how to navigate this conversation to best suit the needs of clients, these different rapport building strategies can be really important. What you're doing with your words and your actions is trying to build a safe space for the client, which ultimately will help you to do your job better. For example, asking open-ended questions is really a way to allow the client to talk and share more, and the pharmacist to talk and share less, but to still obtain that important information about what the client is wanting or needing, or maybe what misperceptions they are under. So good open-ended questions might start with phrases like, tell me about, or how would it be, or possibly why. So the follow-up to an open-ended question is ensuring that you've demonstrated reflexive listening. And contrary to popular belief, reflexive listening doesn't involve repeating what somebody says back to them, but rather figuring out a way to summarize the important points that you've heard and check in with them to make sure that you've understood them correctly. So then rolling with resistance and demonstrating empathy and acceptance are similar concepts, but are not exactly the same. Contraceptive clients have a lot of experience and knowledge of their lives and what they've been doing to date to prevent pregnancy. And we know that their experiences inform their decision making. It is helpful for providers to acknowledge that these lived experiences come with their decision making, even if those perceptions might not be shared or might not be in accordance with the evidence base. So a person might come in and share a story about how they've started the pill and gained 50 pounds. And you might know from the research that it doesn't support that pills cause this type of weight gain as a side effect. But instead of telling that to the client, you could just demonstrate empathy and acceptance by instead something like, yeah, that sounds really challenging. Is there a method you found that doesn't have that side effect on your body? Or and then rolling with resistance is a little bit more centered around finding the place in the patient's needs or story that you can agree with and focusing there rather than the places where you may disagree. And finally, demonstrating to the patient that you respect their privacy and confidentiality. And obviously, this might look different in your different workflows, but even things like ensuring that the client wants to talk about contraception isn't is something that is important for ensuring that privacy is held to. So step 2 is obtaining relevant clinical and social information from the client. And this is really about the process of the contraceptive counseling. So the first part is ensuring that the patient is eligible. And this is where the screener and the algorithm come in, that are those state requirements. And once you have that medical history, the next and arguably most crucial step is to understand those client preferences. So how do you get at those patient preferences? In a typical contraceptive conversation, there are two pretty normal paths that we tend to see. Either a client is coming in with a method in mind that they are already kind of sold on, or they're coming to you to have a discussion about methods in general and get your assistance and support. In the first scenario, the conversation around preferences might be shorter, but there are still opportunities to help clarify with them what they understand, and see if there are places where you can answer questions and fill in some gaps for them. So, for example, if a client says, "Yeah, I want to get on Yaz," you could say something like, "That sounds great. What about Yaz is appealing to you?" And they might tell you about a friend or a family member who recommends it, which is a good opening for you to then talk about what aspects of it were recommended and what things were really appealing to you when they were talking about it. If somebody's coming in to have a discussion about methods that are available, there are some good ways to start getting at those patient preferences with some open-ended questions like, do you have a sense of what's important to you in a method? Or what do you want your method to do for you? Or what are the deal breakers that you have around contraception? Some of those questions can be good ways to get those conversations going. Once you've started the conversation, you might be surprised at all of the different paths and responses that you receive. If a patient isn't sure what's important to them, you can ask some follow-up questions, such as what they want, whether they want or don't want to have a period, bleeding patterns, whether they want something that's taken daily or monthly or weekly, the privacy level of the method, this quickness of the return to fertility. This is not an exhaustive list. People's preferences are going to be really unique, but these are some places that you could start as jumping off points. You can talk through the concept of name brand versus generic, and give them an idea of that cost differential and let them decide. And during and after the exploration of patient preferences, this is a really great opportunity to just demonstrate that reflective listening and summarizing. So I'm hearing that you say that you really don't want to have a period. Does that sound right to you? Step 3 is really after you've worked through those patient preferences, is really selecting the most effective and appropriate contraceptive method. So in this final step, it's working with the client to create that action plan. So you've established your relationship, you've heard their story. Now is the time to help them think through their options and give them the tools they need to use the method correctly. This is really a great opportunity for decision tools or decision aids, and we are going to share some of those decision aids and decision tools that are quite popular at the end of this and talk through a little bit, give you some ideas of them, and if people are interested, we can even send them to you if you'd like them. So we've talked about this process as a way to help clients initiate a method, but really these steps are quite similar for clients who are coming to you to switch methods as well. The reality is that almost everybody who is going to come to you for contraception is going to be, by definition, a switcher, because most people tend to use a variety of methods throughout their lives. And the same key components of this counseling, getting at their preferences, hearing their story and understanding what's important to them, and then helping them use that information, all of these play out very similar, whether it's their first method or their 10th method. So speaking of method switching, it can be really impactful and maybe professionally freeing to see this slide. This is a graphic that shows some qualitative research that our team has conducted, looking at contraceptive journeys. And you can see many people's contraceptive journeys laid out here, and what led somebody to start from one place, to go from condoms to pills to IUDs to fertility awareness-based methods. There are a whole host of reasons that people may change methods over time. And while each of these journeys is different, it's helpful to see how common contraceptive switching is. In fact, a person using reversible contraception from ages 15 to 45 will discontinue or switch methods up to 10 times for method-related reasons. And it's helpful to know this because I think the research shows that what happens in a contraceptive counseling visit isn't really about the method. That decision may be short-lived, but how a person felt in the process, the information that they received and that they took on their journey with them, that's what has those reverberations years down the line. So it's not about their method, it's about that process and that conversation that they've had with you and the information that they're gleaning along the way. All of this is to say that what you're doing is really important and it has impact on people's lives. And we're so grateful that you're here learning about this topic. One of our patient focus group participants said, I'm definitely more comfortable having these discussions with a pharmacist and just going through, these are the medications I take, these are some of the contraceptives I'm looking into, and just seeing if there are any interactions they would counsel or saying, this might not be a good reaction or things like that. We really appreciate the work that you're doing. If you're interested, there are a ton of resources out there on contraception. The Reproductive National Training Center and the National Clinical Training Center for Family Planning, as well as Partners in Contraceptive Choice and Knowledge, all have these really fabulous bite-sized online trainings and recordings across different contraceptive topics, including on methods that are available to clients outside of the pharmacy that we didn't cover today, like Depo or IUDs or diaphragms, if you're interested. Many of you may have heard of Bedsider, which is a really great website for patients who are exploring contraceptive options. But a little known secret is that they also have a website specifically for providers, which is very user-friendly, has lots of interesting articles on prescribing and counseling that you can feel free to check out. And then we here at FPE also have hosted a lot of different webinars that are recorded and available online. And we continue to engage providers throughout Utah each month with our Family Planning Echo series, where people can submit cases or questions that they have and get those answered by our expert clinicians. So those happen the second Wednesday of every month. And if you're interested, please check them out. That is the end of our session. Before we move on to the question and answer part of this, I want to just talk through a little bit around CME credit. For people who are interested in claiming CME credit for this training, we will email you the link and code and instructions for how to do that. And hopefully you can complete the post-webinar survey while we're talking through questions and comments. And I'll share that link again for folks while we have some time for questions. So I am going to turn the time over to Misha to start answering some of those questions if you have them. And I'll say that if people don't have questions, we will go through some of the different counseling tools as well. So ask questions away, and then we'll have some time to talk through these other things.
I didn't see any questions in the chat so far, so please feel free to either throw questions in the chat or to just unmute yourself and ask a question.
Great. Well, if people don't have questions, let's talk through a few of these counseling tools that you can utilize. So there are a bunch of them, and I'll just go through a few of them for you to kind of keep in mind. This is that Bedsider platform that we were talking through, and this is an interactive website that people can go to, and they can click on the different methods that they're interested in and get some information about each of them. And you can pull this up on a client's phone or on your own web page and talk through if somebody's looking for something and kind of they can see each of the methods here in real life. Next one. The next one is mybirthcontrol.com, and My Birth Control is a little bit different because it provides some conversation starters for different folks, including what are the different patient priorities. So if you're interested and kind of running up against some blanks on how to get at patient preferences, these are some that might be helpful. So how well does it prevent pregnancy? How do I use it? How often do I have to remember to take it? Are there any side effects? What if I decide to get pregnant? That's that return to fertility question. And people can kind of click through each method, and those topics are covered under each. Next one. This is the Planned Parenthood platform, and they do another interesting thing that also could be potentially helpful if you're having a conversation with a client. They really want patients to pick the 3 to 5 things that are most important to you in a birth control method. So again, if you're getting at those patient preferences or what aspects of a method are most important to you, these are some ideas for what what Planned Parenthood has found folks tend to select. So preventing pregnancy, sexual pleasure, easy to use, easy to get, reduces periods, side effects, prevents STDs. These are some interesting ideas for kind of how to frame that conversation. Misha, somebody's asking, with a person of a BMI over 30, should they take 2 EC tablets to be effective? And I'll just let you go through that.
That's a great question. So there's some recent data that came out that basically said it may not actually help. The data was done in a very select population. I think my answer to that question is it's not going to hurt. Certainly, if a patient with a greater than 30 BMI has access to ulipristal acetate, that's going to be a preferred method of emergency contraception. But if levonorgestrel or Plan B is the only thing that's available to them, I think taking 2 of those is not going to hurt. And honestly, the question of efficacy is still out there. There's some evidence to suggest it might be, some evidence to suggest it would not be, but ultimately it's not going to do any harm and may have a benefit.
Great. Thank you so much. So this is the Beyond the Pill / Bedsider collaboration with a method sheet. This is a tiered efficacy method sheet, and you can see there are 3 different tiers that people talk about, and this may be helpful for people who are interested in efficacy as the primary thing that they're most interested in. And so it kind of talks through how methods, how well do they work, and then how you want to talk through those methods individually. So you've got IUDs, implants, copper IUDs, and sterilization as the most effective methods, and then short acting methods like the pill, patch, ring as that second tier, and then some of these other methods on the third tier of effectiveness. And again, I think the important thing to talk through with clients who are interested in efficacy is if they're coming to you for a pill or a patch or a ring and efficacy is really important to them, the point is not to deter them from using these methods. The point is to help them strategize how they use the method that they want to use the most effective way that they can. So this can be a helpful conversation point. But again, the purpose isn't to change somebody's mind. It's really to help them strategize on how they can use their method the best way possible. Next slide. So this is a different one, and this is kind of interesting because it's a lot of information on a single sheet. This is the Reproductive Health National Training Center. But one of the nice things about this particular sheet is that it has how to use it and some side effects that I think are really interesting and important pieces that some clients really appreciate. You can go to the next one, if there is one. Yep. And this is method charts from the Reproductive Health Access Project. The nice thing about this is it's specific for folks who are, it can be specific for folks who are breastfeeding. So if you have a client who's recently postpartum, this could be a really cool chart to help them walk through some of the different methods and considerations for that. And then we also have the Partners in Contraceptive Choice and Knowledge. This is a really nice one as well because it gives all of the different places that contraceptive methods are used in this idea of a body, which I think is really interesting and can kind of show. And then they also have this interesting way of displaying effectiveness, which is kind of cool. All of these are just tools that you can use. And this is Family Planning Elevated's tool. You can kind of see here that, again, we've talked about how you use these methods, how you keep them up, whether or not they have hormones, what their efficacy is. And yes, there is a way to get a copy of this. We will be sending this out, and we'll also be hosting the live version on our website. So you can watch it again, hopefully on double time if you are tired of hearing me talk, or you can just have the PDF of these slides, which we will email out. There are a bunch of other decision aids. We also have these really lovely contraceptive cards if you're interested. So one of the nice things that can be helpful with these decision aids, these cards, is if somebody's coming into you and they already have an idea of what they want. So they're coming in and they're like, I just want the combined pill. We have these cards and you can basically just pull out the card with the combined pill, and it gives all of the information specifically about the pill in a larger format that's easier for a quick discussion piece. So if you're interested in getting a copy of these of our method sheets, or if you want a copy of our cards, we would be happy to send them to you. And the cards are available in Spanish as well for Spanish speaking clients, as well as the method sheet. So just let us know if you're interested in those. Like I said, those are at no cost to anybody. We would be happy to send them to you. But also use whatever. We also have, there is another decision aid that many people like. And this one is, based on your own preference, but a lot of people like to touch and feel things. So for those people who aren't necessarily visual learners and maybe more kinesthetic learners, there is this birth control pharmacist kit. And this basically goes through and shows all of the different types of methods with things that people can look at and feel and touch. So for example, you can see here they have a diaphragm, and they have a little IUD. They have a little thing that you can palpate an implant in what's supposed to be an arm. They have different examples of emergency contraception. These are a little bit spendy, but if you have a bunch of people that are coming in to talk to you about contraceptive care, this can be a really nice place for them to kind of explore and see things if you have time. And that's it. Those are all of our decision aids. If anybody has any other questions, we would love to answer them. And if you do not, I am going to put the link for the post-webinar survey into the chat. Please take it. Please tell us what we can do better and how we can continue to support you. And thank you very, very much for all of your attention and support. We really, really appreciate it.